So, first of all, I didn't initiate that project, so I want to give the credit to the primary author, that she had done a fantastic job with this. But there is a story behind it, and the story starts with the State of Oncology Care of America, or the SOCA committee in ASCO. The development of a map technology that investigators could build upon. So imagine you take the map of the United States, break it down into level of zip codes, and now have the ability to overlay on top of that whatever data set you want to play with. So you might say, one of the very first projects we did that got a lot of attention was, where do our cancer patients live, and what is their proximity to centers that could offer them a comprehensive clinical trial menu? And we just arbitrarily said, well, if you have 60 to 100 clinical trials, you're probably a pretty big center. If you have one or two, that's more of a mom and pop opportunity. That's not a bad thing. Anybody who's doing clinical research, I'm their biggest fan. I am such a promoter of community research. I spent my career doing that. But we just wanted to ask a simple question. Where do they live, and how might that impact clinical trial accrual? And what did we find? Not surprisingly, that where the cancer patients live does not always get represented by where the clinical trials are. We are making patients go to those trials. Now you could look at other things. Where do people with cancer live relative to smoking rates? Where do cancer patients live relative to determinants of health, socioeconomic status, race, ethnicity? You can now start mapping and looking at all of these different factors and their impact, in this case, again, on access to clinical trials. Why is there an access problem? We have known for a very long time that our clinical trials don't look like the people we're treating. And we have always been quick to blame the inclusion and the exclusion criteria, and not necessarily paid enough attention to other barriers, whether it be geography, economic, and caregiving issues. There are so many things that might impact that. But we do know there's a problem. We do know there's absolutely a problem. So in this case, the question was, what access to Black women who are disproportionately affected by triple-negative breast cancer, what access does that population, who has historically been underrepresented and marginalized in our clinical trials, have to those trials? And where are those trials? Take the same iterative map, let the investigator have access to this technology, let them have access to the experts who know how to work with them with these tools, and let's try and answer that question. So, where do they live? Well, you can set that on the map. And then now, where are those trials? So looking through clinicaltrials.gov, you can start mapping. Here are the trials. You can break them down by adjuvant, metastatic, and you can lay them on the map and simply ask, is there a correlation? It's not rocket science, but it is rocket science creating the data sets that allowed them to do that. That is rocket science, and it's beautiful science. So, what did you find? Exactly what you'd expect to find, sadly, that a large number of the patients don't live in the area where the trials are being offered. And so, I'm not surprised by that result at all. We've seen that in our trials as we've reported them. We see it today. We'll see it. You go upstairs right now, wander the posters, you're going to see that again. That problem needs to be solved. A poster like this is a call to action. And there have been other posters just like this. They are calls to action, and they're very, very, very important. So I'm proud of the poster. I'm proud of the work that the team at ASCO has done. I think that they are fulfilling the mission of ASCO in terms of answering important questions. I'll take off my hat that is representing ASCO. I'll take off my hat that is representing Sarah Cannon and McKesson And I'm just going to be Dave Waterhouse. We need to start thinking about how do we decentralize trials. Don't make the patient go to the trial. Bring the trial to the patient. That's going to take an effort. But every doctor, every cancer doc could be a trialist, and every patient could be a research subject. And we just have to change that mindset that it can only be done in an ivory tower. It can only be done in a resource-rich community center. It can be done in rural Idaho. It can be done in inner city Baltimore. It can be done in the Pacific. But we have to choose to take that action. I would also like to credit ASCO on another factor. The fact that this poster is even accepted and presented. Real-world evidence, real-world data, has historically been treated as a stepchild to a randomized, placebo-controlled, multi-center, multinational clinical trial. But there are some questions that can't be answered in that setting, such as this, is real-world data, real-world evidence. And historically, you didn't get the high-impact meeting, you didn't get the high-impact journal, but it's now being recognized for the science it is, and the integrity of the data, and the methodologies. This trial was done extremely well by this team. The data sets were solid, they were well validated, the comparisons were done, the conclusions were supported by the findings. These are all the factors that you look at when you're walking by a poster and say, do I believe it? Is this something that, and it aligns with other findings. Does it sit in a world, in a context that is believable, or is it an outlier? So I am proud to be part of this project. I was proud of my tenure with SOCA, and I still feel really good about representing ASCO. I love being part of the Sarah Cannon Research Institute at our site. I love that my community practice, OHC, allows me the opportunity and protected time to contribute like this. So, again, though, we have to listen to these calls to action.